Hi, I'm Richard Ingebretson with the University of Utah School of Medicine. I'm the director of the Advanced Wilderness Life Support Program uh, here. Today we're going to talk about drowning and water safety and the problems that involve that. You can go to wildmedu.org if you haven't already and download the PowerPoint lecture I'm about to give and follow along. This lecture closely correlates to the Advanced Wilderness Life Support textbook and the other textbooks we've written on this subject. So that picture is a good one. It shows a common complication of people who are on river sports. We start off with epidemiology and just mention that this is a drowning is a calamity of the young. 64% of all people who drown or deaths are under the age of 30. Half of fatal and non-fatal drownings in adolescents occur in natural water settings. Swimming pools account for about 20% of drowning deaths. So it really needs to be young people and children. Even though this is a wilderness lecture, you need to be aware that children at home, even in toilets and small buckets, can drown. Little pools and puddles can drown them. So that's really where we have to talk about it. In the wilderness, alcohol is the major risk factor. Males have twice the mortality rate, and in a failure to wear a personal flotation device or a life jacket results in just a staggering 88% of all drowning deaths. This chart here shows drowning rates comparing the male to female, and you'll notice that the young children are the ones that are most susceptible, both male and female. And then as males get older in their late adolescence, they tend to have a greater episode of these drowning rates. This chart can be reproduced for skiing accidents and in car accidents. It's not unusual for that age group of young men to get into these problems. Now, there's a big deal about terminology. Over the years, there have been a lot of different terms to talk about accidental drownings. There's been a whole lot of confusion with these definitions. So in 2015, the International Liaison Committee on Resuscitation, which is ILCOR, recommended these new definitions. They become important because when you start treating people in the field or in the hospital, you'll need to know the exact terms. And in the new categories, the term near drowning, wet drowning, and dry drowning have been eliminated, which have been very common in the past. It is critical to have these so that you know how to treat them because of the ramifications for the victims. Drowning is defined as a process that results in respiratory impairment, which is caused by submersion or immersion in the liquid medium, thus causing death, morbidity, or no morbidity at all. So drowning doesn't mean you die, but it can mean that you die. It just means immersion or submersion. Immersion means to be covered in water, and partial immersion means to be partially covered in water. The drowning process can be thought of as a continuum from the onset of the airway being immersed to when the patient dies. The drowning process can be disrupted at any point by rescue and resuscitation. So those are the important terms. There is another thing called shallow water blackout, which it was defined by ILCOR also. This issue can occur when people hyperventilate before going underwater. The idea is that you take a whole bunch of deep breaths to, so you can hold your breath and stay underwater. The problem with that is that it's not a lack of oxygen that drives our breathing rate. It's too much PaCO2. So as your carbon dioxide rises, then we breathe more. So if you take a bunch of breaths before you go underwater, you breathe out the CO2, which is normally what is used to tell you to come above the water, but you really don't increase your PO2 that much. So swimming in time uses up the oxygen, but there is still a low PaCO2, so there's no internal drive to surface and breathe. And then that hypoxia can cause loss of consciousness and drowning. During the drowning process, the victim becomes panicked, and this causes an increase in respiratory rate. Victims usually then thrust underwater like in a rapid, or they go underwater and then they have to try and hold their breath. This will lowers the oxygen levels while increasing the CO2 levels in the blood. So then as the victim struggles to stay above water, they use oxygen. With the rise of the CO2 and the fall of the PaO2, the medulla in the brain is then going to be stimulated, and that'll cause involuntary respiration. And that is a very powerful drive to breathe. And even though you are cognizant of the fact that you're underwater, the medulla will cause you to take a breath. And then water gets into the lungs, causing pulmonary damage. And if you've been a river runner, like I have, and you've been underwater, that happens to you. It's actually happened to me being underwater, where you just all of a sudden take a breath. At that point, the victim will become hypoxemic, which will cause secondary organ damage. The heart becomes ischemic, and then neurologic injury can result. As far as what happens, the lungs are the primary and target organ of injury. The aspiration evokes this vaguely mediated constriction and pulmonary hypertension. You can get washout and destruction of the surfactant. This can make the lungs stiff and non-compliant. You get a significant ventilation perfusion mismatch and diminished oxygen diffusing capacity. The net effect is hypoxemia. The signs are going to be shortness of breath and air hunger if your victim becomes above water, cough, they can get rales, bronchi, and wheezing if you can listen to the lungs. As far as the heart goes, arrhythmias are very common in drowning victims. It is not caused by electrolyte disturbance such as high calcium, magnesium, or sodium. It is secondary to severe hypoxemia that causes ischemia and then in the cardiac conduction system, which will then lead to the arrhythmia. The hypoxia can cause respiratory acidosis, and that also leads to arrhythmias. 12 to 27% of survivors will sustain some kind of neurologic injury. Injury is usually due to the hypoxemia, but even still, you have to be aware of potential trauma to the head and other parts of the body. Appropriately evaluate the patient with altered mental status. 10 to 20% of those recovered with fixed and dilated pupils will recover. So if someone is drowned underwater, they can have up to a 1 in 5 chance of recovering. The hypoxia causes injury and inflammation in the brain. This can lead to cerebral edema and increased intracranial pressure. This process can occur after a very, very short time underwater and of hypoxia. And that is why it's extremely important that in the management of any submersion injury, that you get air into the lungs. Do not immediately use CPR and chest compressions. What you need to do in any drowning victim is to begin mouth-to-mouth and push air into the lungs just immediately. It's important to monitor them for further neurologic deterioration, as reperfusion injury can occur. So remember that to counteract the hypoxia, get air into the victim's lung just as quickly as you can. Even if they're still in the water, before you can get them out, try and force air into the lungs. Drowning itself is quick and silent. It may be preceded by distress, which is visible. In the early stages of drowning, very little water typically will enter the lungs. A small amount of water entering the trachea can cause muscle spasm. That'll seal the airway, and we've seen that a lot on river trips. And then at that point, unconsciousness can occur, and that creates a bigger problem, of course. This means a drowning person is unable to shout for help as they cannot get enough air. The instinctive drowning response is autonomic reactions before sinking underwater. To the untrained eye, it looks similar to calm and safe behavior. So persons trained in rescue learn to recognize drowning victims by watching for those emotions. So make sure that before you go out on water sports, make sure you're looking to make sure people are, the signs for people who are in distress, which can look normal. And so here's a chart that kind of shows that drowning is not always obvious. Keep watch at all times and look for that. Mouth at water level, things like that, head tilted back, and the others. The field management of water injury and drowning involves bringing the victim's mouth and nose above the water surface, trying to get air into the lungs. A drowning person may actually grab the rescuer, submerging the rescuer in the process. So you want to be careful of that and approach them from behind or carry a life jacket on you so that you won't be drawn underwater. Usually we have the people come from behind twisting the arm or the back onto the victim on their back to restrict movement. And if they're unconscious, you can do that easily. And then their mouth is open, their head is tilted back, and you can actually blow air right into the lungs in the water. It's like they're a lake or a constriction of water on a river. If the rescuer doesn't get pushed underwater, they should dive. If they do get pushed underwater, they should dive downwards to escape the victim and come back up and help them. Since drowning is really an oxygenation problem, rescue breath should be started immediately, like this picture shows. The European Resuscitation Council recommends that 5 rescue breaths be initiated instead of the 2 breaths when starting CPR in a normal victim. So remember, 5 rescue breaths immediately into the lungs, and get air down there before you do chest compressions or anything else. Most patients with respiratory arrest will respond after the first few rescue breaths. Just getting air to the lungs will inflate them and get oxygen to their body. Chest compressions are ineffective without a sturdy surface under the patient anyway, so they should be avoided until the patient is on land. The idea of using the drainage procedures such as the Heimlich maneuver is no longer recommended in a submergent injury, and we don't recommend them. They can cause aspiration into the lung, and it delays getting air into the lungs. The quicker you get air into the lungs, 5 rescue breaths immediately. It's always important to consider trauma as a mechanism of injury in the primary assessment. Cliff jumping has a fairly obvious risk for head and neck injury, as we pointed out in this picture. But if they're on a river, they can hit on a rock. If they're on they're water skiing in the backcountry and they fall, they can get trauma by hitting the water. They can be unconscious. They can damage their neck or break the bones. So the current protocols for wilderness spine immobilization are very similar to the standard criteria on land. They should be immobilized if they have or have altered mental status, intoxication, neurologic deficits, or thoracic or distracting injury. And in that case, you want to immobilize them. The current protocols for wilderness spine are, as we said, similar. In other words, and a decreased range of motion. So drowning in cold water can be protective, but hypothermia has to occur at the time of the submersion. Most patients will be hypothermic from prolonged exposure to the water and are already dead from the drowning process. So the patient can also die from an immersion syndrome, and that is suffering cardiac arrest from the shock of cold water. So someone is on a boat and it's warm or hot out and they fall into the cold water of the river, they can get the immersion syndrome and go into cardiac arrest. In very cold water, reflex reactions can be lethal, killing up to 70% of people in 15 to 30 minutes. Initially, victims first give rise to cold shock. This is a combination of uncontrolled gasping and massively increased blood pressure with possible cardiac arrest. This is followed by the rapid loss of control of bodily functions that are needed for swimming and for gripping. So hypothermia is a real problem. If you fall into a cold river because of this, it's hard to swim out, it's hard to grab, and it may be that you have to help someone even more because of that. As for evacuation, any degree of resuscitation warrants an evacuation in submersion injury. In some cases, however, continuation on the route may be the fastest and safest evacuation plan. Like a river rafting or whitewater rafting trip, it might be quicker to raft the rest of the river and get them out that way rather than wait for help. Because sometimes the quickest way out on a river is just to go down the river. And then as you do that, you can monitor the patient for any complications. And that, of course, is going to be essential. Patients that are asymptomatic after their submersion episode should be reevaluated after 6 hours, something like that. If the patient has a regular exam with no symptoms, no cough, normal breathing sounds, or vitals, they can stay in the wilderness. If there are any respiratory complaints or findings, then the patient should then be evacuated. The unfavorable prognosis for drowning victim is age 3 or younger, drowning for more than 5 minutes, no resuscitation for 10 minutes or more. If they go to the ER and they're comatose, or if their pH is 7.1 or less, if you have 2 of those or less, then you have a 90%, but if you get to 3, then your chance of recovery are far less. So prevention is the important thing. Any action can take, any action that one can take after a submersion incident has occurred. In other words, nothing is better than prevention. On rivers and when you're doing things on lakes, boating, alcohol should be avoided. Always wear personal flotation devices. So many deaths could have been avoided on wakeboarding, skiing, if people had vests on. It should put the person's head above water, even if the person becomes unconscious. And that becomes very, very important. You should camp far enough away from water so that people, especially children, do not accidentally wander into the water. Younger children should always be supervised when around water. And patients with seizure disorder should always be supervised. Uh, in summary, there's different types of drowning, but in the end, the result is sustained hypoxemia. Manage the airway and respiratory status aggressively. Get air into their lungs rapidly. But when you start CPR, make sure it begins with 5 rescue breaths. And always be aware of concomitant trauma in the drowning victim. Okay, that ends the discussion on drowning. And for the slideshow for the University of Utah School of Medicine, I'm Richard Ingebretson, and thank you for participating.